and psychiatric problems of HIV as we used to do initially. Back in the 90s and late 80s and 90s, sometimes the presentation was more, people came and presented with a psychiatric or neurological disorder. Turned out when you did the testing, they were positive, but we don't see that as much as we used to. However, it still constitutes a serious psychiatric and psychological problem. One of the reasons is that HIV is neurotropic, and it targets the cells of the nervous system. The other one is that when somebody is HIV positive or having AIDS, that means they've converted from just being positive to having clinical symptoms. This is still related to certain psychological and social implications. Now, and individuals suffering from HIV infections have been found to present with a variety of psychiatric syndromes at a rate greater than would be expected in the general population. We've had studies done, a lot of studies now done in patients with HIV, even children. They have a higher psychiatric morbidity than the general population. We have had them done in adults, again, with very particularly very higher prevalences of depression, between 30 and 40%. Depression, that's much higher than the general population. And then we have currently a high prevalence among adolescents who adolescents who were peripartum HIV infection and who have lived on ARVs, but who at adolescence during that transition have problems transiting into adolescence and at the same time using their medication. So we have at the current moment, that is probably the most problematic age group. Now, the other thing with infection with HIV, as we say, because of the neurotropic tendency of HIV and because of the psychosocial implications, may, like we say, predispose a person to becoming mentally ill. The other thing is that being mentally ill may also predispose a person to getting HIV infections. And we look at the conditions in psychiatry which predispose people to getting mentally ill. Now, the most common manifestation, that's better. Most common psychiatric manifestations, like I mentioned, are depressive spectrum disorders. And a lot of times it may be comorbid with anxiety. The most common neurologic manifestation is HIV delirium, followed by the minor cognitive and motor disorder. And then you have the HIV-associated dementia, which, like I've said, we used to see a lot of this, but with ARVs being readily available and most patients who have AIDS have access to ARVs now, we have seen less and less of this disorder. Now, look, like I mentioned, persons with HIV or AIDS may present with organic psychosis. This may range from mild cognitive impairment to severe dementia and delirium, which is an acute confusional state. They may also present with mild to severe behavioral change. If my internet disappears, please somebody call me, because I can see it saying that it's becoming unstable situation. So they may have psychosis, mania, depression, and the presentation may mimic functional psychosis. That is why currently, all patients who present with mental illness, we recommend testing. Of course, that is diagnostic testing and counseling must be done. Should not just go and test people without talking to them. Then the premorbid psychiatric conditions which may predispose to HIV include alcohol use, alcohol dependency, any of the alcohol use disorders from alcohol intoxication, alcohol abuse, alcohol dependence, drug abuse. And with drug abuse, the particular one are the intravenous drug use. We know that a lot of patients who or persons who have been on intravenous drug use in this country are also HIV positive. That is because of sharing needles. And manic states, people with manic states can also predispose to HIV infections, particularly because of the disinhibited behavior, tendency to have indiscretions, particularly sexual indiscretions, and multiple sex partners while they are in a manic state. Now, intoxicated, disinhibited individuals are more likely to impulsively participate in risky sexual behavior. Risky sexual behavior means person is in a pub, gets intoxicated, and is more likely to have impulsive sex with a partner that they do not know, people they do not know or have just met. And they are also less likely to use, when they are intoxicated, to use protection. Now, I give you a case study here, which just shows how this happened. And this comes off quite a lot. Like in this case, had a 50-year-old male accountant admitted with a history of confusion, wandering around naked. Aggression, was attacked by the mob, but could not remember the exact event, was attacked by the mob for aggressive behavior and walking around naked. He was separated in 2012 after a bad fight at home where he attacked the daughter. He had been drinking alcohol since he was in Form 2. And that had put it, I think that is more than 20. They had indicated 27, but surely Form 2, that must be more than 20, maybe 37, more likely 37 years, not 27, should change that. And he separated like that in 2012 because of alcohol, because when he attacked the daughter, he also was intoxicated. He had been in rehab twice, but didn't stay for long. He disappeared. And quantities of alcohol vary from 8 bottles of beer to 250 mLs or 500 mLs of alcohol, that is, per day. However, the patient denied drinking daily. He said he's a serial drinker. He said, I can't drink if I don't have money, but when I make a killing, then I really drink. He drinks it to the end. And, he was still getting jobs as an accountant. After separation, there was a history of sexual relationship with sex workers. And then in 2018, he tested positive. So you see, he had this background of alcohol abuse, alcohol dependence, with some stays in rehab and a separation, and tested positive in 2018. Of course, we do not know, we cannot know that whether he was positive before 2012. But this is usually one of the sequences of events that happen. People with alcohol dependence end up in a lifestyle where they live away from home and have casual relationships and relationships with sex workers. And he was put on HAT and discontinued. He had discontinued at the time we were doing this case, which was 2019, and then restarted. You do know that the problem with the starting people who have alcohol dependence on ARVs is that they have poor adherence. And because of that, they develop resistance to the first line drugs. Now, so to understand the psychological aspects of HIV/AIDS, it's good to look at it from what we always do, the biopsychosocial model. Look at the biological aspects, that is the organic changes caused by HIV to the brain, and to other organs as well, for example. And then the psychological aspects, which are range from suspicion. When one has a certain experience in life, which they felt was risky, then there's the suspicion that one may be HIV. And the other one are the implications of actually going for the test and being positive. It's not an easy journey, even now. It's become lighter because it is being HIV positive is not a death sentence anymore, but it is still not easy. And then the social aspects are related to the environmental reactions to HIV/AIDS. And we look at each of these directly. So we look at the biological, we look at the direct invasion of the brain by the virus, and then we look at the immune reaction through brain immune cells, which itself can destroy brain cells. We look at opportunistic infections. You should know more about these ones than I do, because these are very one of the biggest problems with HIV in medicine. Secondary spread of cancers, like there are certain cancers which more likely to happen, the Kaposi's sarcomas, for example, with HIV. Then you have the systemic opportunistic infections, and the other systemic symptoms and metabolic derangements when somebody has severe disease. Now, the virus has been found diffusely throughout the brain, the virus itself, in the cortical white matter, subcortical gray structures. And the microscopic exam have shown that infection by the virus of the microglial cells, macrophages, and multinucleated germ cells. And then there's the long-term HIV replication in the brain, and the astrocytes and the microglial immune destruction of the neurons. This is the immune destruction. These are the immune cells which also destroy the neurons and not just the virus. This is a common problem that we're having also with COVID, that the immune cells also cause a lot of devastation on the tissues. Now, HAT has increased the life expectancy of people living with AIDS. And the neurocognitive dysfunctions are now complicated by aging, because before the life was short, maybe 10 years without ARTs, then now we have where we have people who are aging with HIV. In addition to the normal aging process, just give me 1 minute, I need to check it too. there is, let's sort out a little problem here. So we have HIV-associated neurocognitive disorders like HADS or HIV-associated disorders are now accelerating.
Professor, we can't hear you.
Okay, I've just unmuted myself. So just give me 1 minute to get back. No, I got muted. I think I'm back.
Yes, Professor, we can see the screen.
Okay, good. Okay, fine. Let me get back to. So HIV-associated dementia defined as acquired abnormality, cognitive abnormality in 2 or more domains, and is associated with a functional impairment and acquired motor or behavioral abnormalities. But predominant thing is the cognitive abnormality. And then the lower end of the continuum, you have the asymptomatic neurocognitive impairment, meaning that if you do neurocognitive tests, you will see some impairment, but they may not come out very clearly in day-to-day life, like the minor memory deficit, the minor deficits in attention concentration, and there are tests that psychological tests that we use for doing this, like I think it's called the HADS test, to detect the finer asymptomatic neurocognitive impairment. And then you have the HIV-associated minor cognitive motor dysfunctions. And then the HIV-associated dementia and the minor cognitive motor dysfunction are also associated to metabolic encephalopathy related to both the host and viral neurotoxicity. Like we've mentioned, the virus attacks the neurons, is present in the brain, and then we have the immune reaction. And we say that the viral loads of more than 3,000 copies per ml are 8.4 times more likely to have HIV associated dementia. Now, the problem, like I mentioned, with patients who may have other psychiatric comorbidities is the problem of adherence to treatment, which means that because they keep going on and off treatment, there's more resistance, and they are likely to have higher viral loads. Now, the risk factors for HAD is age. The older you get, the female sex is more likely to get it or more at risk. Then, of course, the HIV staging, and then the comorbid hepatitis B and C, and the comorbid intravenous drug use. These, I just want to point out, are also risk factors which are shared with major depressive disorder. That age, female sex, disease staging, and comorbidities are also risk factors for major depressive disorder. So that is one of the reasons why these two things go together, just one, because of including neurological changes, structural changes. So with HAD, there is a global intellectual decline. There are deficits in memory, concentration, calculation, abstraction, and judgment. These are the cognitive functions. And when you say global intellectual decline, it is that all of them are impaired: memory, concentration, calculation, abstraction, judgment. Then there's oops, did I just change? Mental slowing. The person is slow. And we have some neurocognitive tests which we do to look for this. And there are personality changes. Now, personality changes are those changes in the personality that you can only detect when you're close to the person. So usually we get this feedback of personality change from the people who are close to the patient. These are the neurological symptoms, which include coordination, ataxia, motor slowing, tremors, hyperreflexia, lower extremity weakness, autonomic dysfunctions, and agitated behavior. Now, opportunistic infection, we mentioned, they also may be related to either focal changes, in which case you expect focal symptoms, or diffuse infections of the CNS, encephalitis, meningitis, plasmosis, the progressive multifocal encephalopathy, bacterial or fungal abscesses, and these will present with behavior changes and focal neurological signs depending on where the focal lesion is. So that will be one of the key things. Depends on where it is. Then I mentioned diffuse meningitis. Cryptococcal meningitis is very common among patients with HIV who have AIDS, encephalitis, neurosyphilis, bacteria, and viral. Patients may also present with delirium, with or without psychotic features, or even present with just depression. But usually the depression will also show very exaggerated neurocognitive dysfunctions, which are not as common as in just depression. Then you have your systemic opportunistic infections, pneumocytosis, pneumonia, tuberculosis, cytomegalovirus, which cause delirium on the basis of septicemia and pyrexia. Then you have your tumors, the Epstein-Barr virus, lymphoma, and the Kaposi sarcomas, and the lipomas, which have been associated with HIV/AIDS. Many years when I was a medical student, long before it was found out the HIV virus was discovered, we used to be told that Kaposi sarcoma in East Africa was very common in Uganda, more common than in other places. And a lot of times when we saw patients, they came from that side. And it is later thought that, of course, that the HIV virus was present in certain parts of Eastern Central Africa long before the the first cases were diagnosed and the virus identified in the early 80s. Now, other organic related factors include the anemias, vitamin B deficiencies, B12, and metabolic derangements, which may present with symptoms that mimic psychiatric disorders, suggestive of depression, anxiety, fatigue, and cognitive changes. Again, we do know that this kind of metabolic derangements or vitamin, they are also very common among people who have alcohol use disorders. Not one, which is probably alcohol use disorders. It's one of the commonest problem in psychiatry in our country. Now, let's move from the biological to the psychological aspects and start with the person who thinks that they have had risky encounters. And this is suspicion that one may be HIV. Suspicion, testing positive. And then there's the conversion from non-clinical to clinical, sustaining adherence to treatment and safe sex in HIV. So like we say, suspicion is that knowledge of sexual indiscretion. There's also this when you know that a partner, your partner, sexual partner has died or is HIV positive, like when they do tracing and then somebody tells you your name, you was given as one of the partners of one of the people, we want you to come for testing. Then there's a lot of anxiety associated with this. It has become better because it's easier to test for HIV. There are many testing places. Before, people used to like even move from the town they live in to go and be tested in another one because they don't want people to see them in that clinic, what will happen. So if you live in Thika, you come to Nairobi. If you live in Nairobi, you go to Machakos, So that anxiety. Then you have something called the worried well. That is people who are always worried that they may have HIV positive, and very specific to HIV. Of course, we have anxiety disorders that where people always think they have like hypochondriasis. But we have some who only think they have been in relation to HIV. We have patients, we've been having patients who we been seeing in the clinic who go for testing every other week until they're chased away by the testing people. Say, you were here last week, yeah, but now this happened. I was sitting in a matatu when I woke up. It could have been blood of somebody who was HIV. Or I went and I walked near somebody and they touched me and, stress, but they're still there because the kind of stress around HIV has reduced a lot. But they're still there and you still see them and eventually they are referred to psychiatry. Now, when testing positive is associated with acute stress reactions, shock, fear, guilt, despair, depression, but these are usually short term. And like I say, if somebody has had proper pre-test counseling, this is less. We used to have a lot of problems when this was not so widespread, the pre-test counseling. Patient used to be tested and then they just told you, you have HIV, and then they go into shock. Some committed lots. In the 80s, 90s, a lot of patients committed suicide because of positive results. A lot of them went on a rampage to infect others. And you've had cases like that, maybe they've been around, where somebody decides, if I have HIV, I'm going to infect other people. Then you have adjustment disorders, which is something we say, again, related to poor counseling. and characterized by morbid responses, anxiety, depression, somatization, and that's what I mentioned, the high suicide. Then there are people who are HIV positive for many years before they convert from non-clinical to the clinical status. And that conversion, can also have some implications in terms of anxiety. So some of the reactions that go through them is other disease progression. People start thinking about body image. This again has become less. There was a tendency before the ARVs that people who had HIV were looking very, very thin and, so, but this has changed. This has changed a lot. But some people still are obsessed with those images, those images haven't quite gone away. We still see people say, who are worried about what will I look like now that I have AIDS. They also worry about the loss of health, chronic debilitating illness, and mortality. Again, like I've said, it has become very clear that HIV is not a death sentence, but it doesn't mean that everybody is reacting to being positive by saying, okay, I'll just take medication anyway. There's still people still worry about illness, debilitating illness, and mortality. And they also worry about dependence when they have them. Just for your information, is like before, one of the interesting projects that was there before ARVs and was very well worked out in Uganda is what they used to call it a diary. That was before the ARVs became popular, accessible, available. And it used to be because people used to worry so much, what about my dependents? Who will take care of them? You see, people who are HIV positive were people in the reproductive age groups, okay? And in fact, there were in the 90s and early 20s, a lot of HIV, some of them have a HIV positive, some are not. And people were worrying, I'll die, the father will die, or the mother, both parents will die. What is going to happen to them? Will they be able to get our property? Will they know who we were or where we're coming from? And that started this journaling for their dependents, where they would indicate who they are, who has their lineage, what is their clan, the kind of things you get from your parents as you're growing up. And where is our property? What do we own? What is rightfully yours, And putting together in a book, which would be kept for the dependents. But I haven't, nobody really talks about such projects very much anymore because a lot of people who are HIV are on treatment. And actually, the highest mortality is in the adolescent age group because of what I mentioned, that problem of transiting into adolescence while taking treatment. So worrying about the fate of the dependents, adherence to treatment like that, strict adherence to treatment is so important. And just for example, I was just looking, one of my master students was looking at adherence to treatment among adolescents in some clinics in Nairobi. And I found that poor adherence in, I think, 96% of the adolescents, poor adherence. There is a test for testing adherence called the Morinsky adherence test, which look at how you're taking your medication, how much you've missed in the last 2 weeks, whether you take at the right time, and it is so low. It's devastating low, because low adherence, poor adherence to treatment means moving from first line to second line to third line medication. And one of the problems that adolescents have with adherence is that they do not want their friends to know they take medication. Like when they transit into high school, some high schools have a rule that all children who are on medication leave their medication with the school nurse, and they have to go and collect every morning. So it becomes very stigmatizing for them, because the other children say, but what is your problem? You don't look bad. You don't have a disease. So what's wrong with you? Why do you go to the nurse every day? And so on. But there are many reasons. There are many reasons why adolescence is a difficult phase anyway, and becomes even more difficult when you are on ARTs or ARVs. And of course, it is also compromised by psychological status. People who suffer from depression, and we have many studies on this, are more likely to have poor adherence. They are more forgetful. They are more likely to, so what? I don't care anymore about myself. I could as well die sort of attitude. Anxiety, alcohol and substance use disorders, I restate, is one of the factors that leads to poor adherence to treatment. Wait, one other thing, yeah, it comes in the social aspects, stigma and moral judgment. People who've been judged morally for, when if in case you don't know, because you are it is that when HIV appeared on the scene, for example, HIV, like I say, was not first diagnosed in East and Central Africa, but was first diagnosed in Los Angeles. San Francisco, was it? Was it San Francisco? And it was diagnosed in the gay community phases of that pandemic. It was considered a disease of homosexuals. So it had a lot of stigma, because people who are gay tend to be seen as being, and then when we started making the diagnosis in Kenya, it became associated not with the homosexuality, but with heterosexuals. But there was a very high prevalence among people who were sex workers. So again, it started being a question of morals. My erratic.
Professor?
Sorry about that. Yeah, I know I got lost. How far? Not far. I was just talking about the moral judgment. Is that correct?
Yes,
Okay.
yes.
Okay, let me share the screen again. Hey, I was far. How come it went down? And slideshow resume. Slideshow. So I was talking about the stigma and the moral judgment. There was others, loss of dignity associated also with the stigma, HIV positive. Children were kicked out of school. You remember those days? No, you don't, because you are probably very young, but you probably have read about it if you read about the history of HIV in this country. Then there was that loss of friends and family. People are kicked out from their homes. There was isolation and loneliness. This kind of stigma around HIV is still there. People still get isolated and lonely, so that people form the support groups. HIV support groups have become an important part of care. And the levels of suicides have definitely gone down, but are still high among people with low social support. Social support is one of the most important element of human beings. We are social people. We are social animals. And we very much value that contact with others, even when we are not HIV positive. Poverty and limited access to health facilities and ARVs, is still a problem, but it is not as much as a problem as it used to be. Most people are able to access health facilities. Of course, you've heard about times when there was shortages of ARV, people who live far. We have some of the programs, HIV programs, even deliver ARVs to patients, but poverty is still a problem. Some people still say, I can't take my drugs because I didn't have food. Okay. Nothing says you can't take ARVs when you don't have foods, but people still believe you can't take ARVs when you're hungry. I have no food, so I don't take medication. Now, I've talked about the role of spiritual aspects. I've talked about the initial stages of the pandemic, where spirituality, religion, was one of the biggest negative problems of HIV, creating a lot of stigma because of moralizing, saying, yes, are sinners. You see these homosexuals, they are sinners, they need to be saved, they need, but it quickly transited to the situation where support, a lot of religious groups and churches offer a lot of support and care for people with HIV/AIDS. So there has been they're still used once in a while. You still see people who are being judged by the religious community, but it's more the tendency now is more that they're offered support. Now, the psychiatric disorders, like I said, I mentioned this, prevalence is as high as 40%, 30 to 40%. That is very, very high, even now. Then you have a prevalence of bipolar, which is sometimes manic episodes, which can occur in the early infection as well as later. And then you have your anxiety disorders, generalized anxiety, panic attacks. And then you have the less severe, the adjustment disorders. We call them adjustment because they resolve after one sort learns to live with whatever it is crisis they are in. Then I talked about the worried well and the HIV phobics, who are in a special category themselves. They're very difficult to manage. And they just keep on getting tested and tested. Whatever they do, they think is a risk. Then you have the substance use and abuse disorders. These are the most difficult people. One of the biggest, the intravenous use, drug use. Some of the programs have been to reduce harm, and includes needle exchange programs. And the needle exchange programs have been attacked by the society. They don't think it's useful. We had some clinics which were closed, I think, at the coast, a needle exchange program, because the community doesn't want them. They say we encourage people. That's not true. Needle exchange program means that if you're a heroin addict, injecting heroin addict, you go, you get a clean new syringe, and then you give your old one, you get a new one, or you get just a clean one and it's thrown away. Come tomorrow and get another one. Okay. So that is how the program works. But we now have the Methadone Clinics, that is the medically assisted treatment for heroin, which discourages people from using injectable and gives them the syrup of methadone to replace the heroin. Of course, the idea is that gradually you'll also be able to get out of the addiction to heroin is very, and the methadone clinic, work in there, ask them if you're interested in what is it they do, and find out what doses of syrup do they give. These are some of the projects that have really helped to reduce spread among patients who have heroin addiction. Oops, it looks like that was the end. Okay. Then, are there any questions? Please put on the chat if you have any questions. That was that lecture. Any questions? I'm waiting to see whether anything pops up. I have another meeting at 9, so I have only 4 minutes to dash to the next meeting. Okay, then let me assume there isn't much, but I would really, since you found HIV at a certain stage where a lot has changed, it's still good to look at the historical background of HIV in our setting here, and to understand where we're coming from and how far we have come. Indeed, we have come a very long way with HIV. Kindly elaborate what worried well. This worried well are the people who I said they are not HIV positive, but they worry all the time that they could have acquired the infection. And they go for testing. They go for testing and they still find they are negative. Then they sit in matatu, they touch. I was walking out of the toilet and I touched the door, and all kinds of things why they need to. That's why we call them the worried well. I don't know why hard is more common in women. We do know that women also, because of the surface area for the infection, but I don't know why hard. We also know that depression, women are more predisposed to depression as such. So I don't know whether there's that link that way somewhere. I don't know, but I promise you, I'm going to look for that. And you go look for it as well. My source of references are the same as you, as I'm going virtual to look for the answer to that, and you can too. But I'm sorry, I don't know. I think it might be just like we don't know why women are more predisposed to depression. If there are no other questions, you'll excuse me and I'll go to my next meeting. Have I missed something else, Lavender? I don't know, Mwango. I think you're the one who contacted me, or the class rep, whoever you are. Oh, it's Lavin. Okay, not Lavender. It's Lavin. Lavin, have I missed something else?
Yeah,
I
we
know I've
have.
got, what?
Yeah, there's a class.
What have I missed?
Let me check the schedule.
Yes, please.
Yeah, we have missed a class on medical conditions.